Hello, I'm Dr. Solomon Aronson, Professor Emeritus in the Department of Anesthesiology at Duke University School of Medicine. I have served on the Joint Commission and AMA Task Force for Overuse, as well as the FDA as a consultant after previously having served on multiple advisory committees. I was also the lead investigator of the ECLIPSE trial, which we will be discussing today. In addition to the results of the study, we will talk about CLEVIPREX, or clevidipine, and the consequences of fluid overload. CLEVIPREX is a dihydropyridine calcium channel blocker, indicated for the reduction of blood pressure when oral therapy is not feasible or not desirable. CLEVIPREX is contraindicated in patients with allergies to soybeans, soy products, eggs, or egg products, defective lipid metabolism seen in conditions such as pathologic hyperlipemia, lipoid nephrosis, or acute pancreatitis, if it is accompanied by hyperlipidemia and severe aortic stenosis. Complete important safety information for CLEVIPREX will be presented at the end of this video. Fluid overload in critically ill patients is a challenging clinical dilemma, and many intravenous medications in the U.S. are administered as dilute solution that can contribute to increased fluid intake. Intake of excess fluid may impose potential adverse effects on multiple organs of the body, such as the lungs, kidneys, liver, GI tract, and the heart. In addition, the impact of fluid overload has been shown to be associated with higher mortality, prolonged hospital stay, longer stay in the ICU, a need for ventilator usage, and increased risk of 30-day readmission. A proactive and reasonably conservative approach to fluid management is recommended as a strategy to maintain optimal fluid balance. CLEVIPREX is an antihypertensive agent that offers low-volume dosing and perioperative blood pressure reduction. Please note that CLEVIPREX has not been studied or proven to impact fluid overload. To look at differences in fluid intake, an often overlooked data point, let's review the ECLIPSE study, which investigated safety and efficacy of CLEVIPREX compared to other blood pressure-lowering agents in the perioperative and postoperative settings. ECLIPSE was comprised of 3 parallel, prospective, randomized open-label studies of 1,506 patients undergoing cardiac surgery who were randomly assigned to receive CLEVIPREX or a comparator antihypertensive agent. In the 2 perioperative arms, CLEVIPREX was compared to nitroglycerin and sodium nitroprusside. And in the postoperative arm, CLEVIPREX was compared specifically to nicardipine. The primary endpoint evaluated safety, defined as the incidence of death, myocardial infarction, stroke, or renal dysfunction at 30 days. The study was not powered for non-inferiority or superiority. The secondary endpoint assessed efficacy by measuring the magnitude and duration of blood pressure excursions outside a predefined systolic blood pressure range. Blood pressure control was assessed using the area under the curve, or AUC, which measured the magnitude and duration of systolic blood pressure excursions outside a predefined pre- and postoperative systolic target range of 75 to 145 millimeters of mercury, and the predefined intraoperative systolic blood pressure range of 65 to 135 millimeters of mercury. In this figure, the reported numbers show how well each agent controlled blood pressure. You can see how each agent performed across individual ECLIPSE trials in the perioperative setting. In the postoperative setting, CLEVIPREX was similar to nicardipine in keeping patients' blood pressure within a pre-specified range. The pooled data from the overall CLEVIPREX population also demonstrated that CLEVIPREX kept blood pressure within the pre-specified range. Moving on, this table compares CLEVIPREX and nicardipine dosing in the postoperative setting, which is only representative of 2 treatment arms from the ECLIPSE trials. Dosing in the ECLIPSE trials was based on patients' weight, while dosing described in the prescribing information is not weight-based. However, the actual doses administered to patients in these trials and recommended by the package insert are similar. Here we see the median results for overall drug administration. As a reminder, CLEVIPREX is not shown to benefit or influence fluid volume. Note the total infusion volumes and average infusion rates. Taking a closer look at this data, nicardipine was infused at a median average rate of 33.6 milliliters per hour, and CLEVIPREX was infused at 7.9 milliliters per hour. The infusion rate of CLEVIPREX was therefore 4 times lower than nicardipine. This may be impactful if multiple agents are contributing to a patient's fluid load or when infusions are administered for longer durations. Further prospective research is warranted to assess the impact of patient outcomes, as the data presented is observational and should not be overinterpreted. Serious adverse events at day 7 or discharge were similar between CLEVIPREX and all comparators, including rates of atrial fibrillation and acute renal failure. Other important notes about safety include the fact that serious adverse events reported within 1 hour of the end of the infusions were similar for CLEVIPREX and all comparators. And there were no adverse reactions that were greater than 2% more common with CLEVIPREX compared to the average of all the other comparators. Rates of drug discontinuation due to adverse events were 5.9% for CLEVIPREX and 3.2% for all the other active comparators. Before concluding this discussion, let's consider some of the features of CLEVIPREX and ecardipine. Both of these agents are ready to use. However, the choice of which one may depend on the clinical scenario at hand. Pharmacological characteristics and dosing options may be important factors to consider prior to selecting the appropriate treatment. It's important to note that clinical studies have not established that the above characteristics or dosing results in superior efficacy or safety based on clinically relevant endpoints. If fluid overload is a concern during rapid blood pressure reduction, consider CLEVIPREX, which has low volume and non-weight-based dosing. CLEVIPREX is available in ready-to-use 50 milliliter and 100 milliliter vials. Based on an infusion rate of about 4 to 6 milligrams per hour, the 50 milliliter vial will last about 4 to 6 hours, and the larger 100 milliliter vial will last about 8 to 12 hours. More information about the ECLIPSE trials or CLEVIPREX is available on the website and in the full prescribing information. Remember, for low-volume dosing that provides titratable blood pressure control, consider CLEVIPREX. Thank you for watching, and please stay tuned for the full important safety information.
CLEVIPREX is a dihydropyridine calcium channel blocker indicated for the reduction of blood pressure when oral therapy is not feasible or not desirable. Important safety information. CLEVIPREX, clevidipine, injectable emulsion, is contraindicated in patients with allergies to soybeans, soy products, eggs, or egg products. Defective lipid metabolism seen in conditions such as pathologic hyperlipemia, lipoid nephrosis, or acute pancreatitis if it is accompanied by hyperlipidemia, and severe aortic stenosis. CLEVIPREX is intended for intravenous use. Use aseptic technique and discard any unused product within 12 hours of stopper puncture. Hypotension and reflex tachycardia are potential consequences of rapid upward titration of CLEVIPREX. If either occurs, decrease the dose of CLEVIPREX. There is limited experience with short-duration therapy with beta blockers as a treatment for CLEVIPREX-induced tachycardia. Beta blocker use for this purpose is not recommended. CLEVIPREX contains approximately 0.2 grams of lipid per milliliter, 2.0 kilocalories. Lipid intake restrictions may be necessary for patients with significant disorders of lipid metabolism. Dihydropyridine calcium channel blockers can produce negative inotropic effects and exacerbate heart failure. Monitor heart failure patients carefully. CLEVIPREX is not a beta blocker, does not reduce heart rate, and gives no protection against the effects of abrupt beta blocker withdrawal. Beta blockers should be withdrawn only after a gradual reduction in dose. Patients who receive prolonged CLEVIPREX infusions and are not transitioned to other antihypertensive therapies should be monitored for the possibility of rebound hypertension for at least 8 hours after the infusion is stopped. There is no information to guide use of CLEVIPREX in treating hypertension associated with pheochromocytoma. Most common adverse reactions for CLEVIPREX, greater than 2%, are headache, nausea, and vomiting. Please see full prescribing information for CLEVIPREX at cleviprex.com.